Retinal venous occlusion, hemorrhagic infarction of the retina. Etiology, incidence, central retinal vein occlusion 15%, branch retinal vein occlusion 85%, 70% supratemporal branch vein. Systemic risk factors, age more than 50 years, atherosclerosis, systemic hypertension, male sex, elevated body mass index at the age of 20 years, diabetes mellitus, risk factor for central retinal vein occlusion. Local risk factors, primary open-angle glaucoma, papilledema, and large optic disc drusen. Etiology, young patients, hypercoagulable status, oral contraceptives, diuretics, hyperviscosity status, blood dyscrasias, polycythemia vera, dysproteinemias, Waldenström macroglobulinemia, multiple myeloma, hypercoagulable status, hypercystinemia, protein S and protein C deficiency, increased clotting factors 7 and 9, vasculitis, sarcoidosis, and systemic lupus erythematosus. Retinal venous occlusion is mostly related to arterial disease. Sclerotic artery compresses vein within common adventitial sheath, inducing turbulence, endothelial damage, and thrombosis of central retinal vein. Site of obstruction reflects severity of ischemia. Obstruction at or anterior to lamina cribrosa results in ischemic central retinal vein occlusion, 35%. Obstruction behind lamina cribrosa results in non-ischemic central retinal vein occlusion, 65%. Pathology, early stages, edema, cystoid macular edema or optic disc edema, papillophlebitis, hemorrhages, numerous deep and superficial hemorrhages, extending in all quadrants, full thickness retinal and pre-retinal hemorrhages, hemorrhagic detachment, focal necrosis, hemorrhagic infarction, cotton wool exudates, retinal detachment in branch retinal vein occlusion due to atrophic holes formation. Late stages, disruption of inner retinal architecture, marked gliosis of inner retina, thick-walled vessels, hemosiderosis with hemosiderin-laden macrophages. Complications, neovascularization, iris neovascularization, 60% of ischemic central retinal vein occlusion in patients older than 40 years, onset more than 6 weeks and up to 6 months following occlusion. Risk factors for new vessels at the iris, poor initial visual acuity, wide area of retinal capillary non-perfusion on fluorescein angiography, intraretinal blood, neovascular glaucoma, 100-day glaucoma, 20% in ischemic occlusions, retinal neovascularization seen in branch retinal vein occlusion. MVDs and MVEs, new vessels at the disc and new vessels elsewhere, are much less common. Late stages, optociliary shunts, large veins connected to choroidal or retinal circulation at optic nerve head, central retinal vein recanalization, recanalization with endothelial proliferation follows venous obstruction. Prognosis, visual prognosis in branch retinal vein occlusion, acute occlusion, macular edema, retinal hemorrhages, perifoveal retinal capillary occlusion, chronic occlusion, macular ischemia, cystoid macular edema, pigmentary maculopathy, subretinal fibrosis, and epiretinal membrane formation. Retinal ischemia in branch retinal vein occlusion. Retinal ischemia more than 5 disc diameters results in NVEs and MVDs. Vitreous hemorrhage, tractional, rhegmatogenous retinal detachment. Retinal venous occlusion, ischemic central retinal venous occlusion. 10 disc areas or more of retinal capillary non-perfusion on fluorescein angiography. Site of occlusion anterior to lamina cribrosa. There is relative afferent pupillary defect, venous dilatation and tortuosity, dot inflamed hemorrhages. Macular edema is present, cotton wool spots are seen. There is prolonged arm to retina circulation on fluorescein angiography. 10 disc central retinal artery occlusion, ischemic infarction of the retina. Etiology, atherosclerosis related thrombosis of central retinal artery at or posterior to lamina cribrosa, 80%. Emboli, cholesterol emboli, Hollenhorst plaques, 73%. Arising carotid arteries, showers of minute, bright refractile crystals at arteriolar bifurcation. Rarely induce significant obstruction. Platelet fibrin emboli 15%, associated with large vessels, arteriosclerosis, carotid plaques, dull gray elongated particles, fill the lumen. Platelet fibrin calcific emboli 11%, arise from atheromatous plaque or diseased cardiac valves, single white plaques, induce obstruction of retinal arterioles. Rarely, tumors, atrial myxomas in young patients, fat emboli, long bones fractures, septic emboli, infective endocarditis, talc emboli, intravenous drug abusers. Vasculitis, giant cell arteritis, 1 to 2% of cases, collagen vascular disease. Pathology, early stages, platelet fibrin thrombus within the atherosclerotic artery, coagulative necrosis affecting inner retinal layers, nerve fiber layer, ganglion cell layer, inner part of inner nuclear layer, pycnosis with edema of inner retinal layers, and cotton wool spots. Macular cherry red spot, window of thin transparent foveolar retina surrounded by opacified infarcted tissue. Late stages, inner retina becomes acellular, thickening of the wall of retinal vessels. Outer retina is normal. Systemic arterial hypertension. Systemic arterial hypertension means diastolic pressure more than 90 mm mercury, systolic pressure more than 140 mm mercury. Pathology. Hypertension induces changes affecting retina, choroid, and optic nerve. Ocular changes may be the first diagnostic sign of systemic hypertension. Changes depend on duration, severity, rapidity of onset, and age of patients associated. Hypertension induces focal vasoconstriction of retinal arterioles through autoregulatory mechanisms. Severe ischemia results in fibrinoid necrosis of elastic lamina, elastin stain, muscular and endothelial necrosis with vascular dilatation and leakage of plasma from the vessel wall. This is followed by occlusion, hemorrhage, and infarction. Leakage results in edema, exudate, serous retinal detachment. Acute hypertension results in hypertensive retinopathy, modified Sheik classification. Grade 0, no changes. Grade 1, barely detectable arterial narrowing. Grade 3, obvious arterial narrowing with focal irregularity. Grade 4, Grade 2 plus retinal hemorrhages with or without exudates, common in renal retinopathy. Grade 5, Grade 3 plus disc swelling. Hypertensive retinopathy, ocular association of hypertensive retinopathy. Branch retinal artery occlusion, branch retinal vein occlusion, central retinal vein occlusion, retinal arterial macroaneurysm. In diabetics, associated hypertension results in severe diabetic retinopathy. Hypertensive choroidopathy, acute hypertension in young adults. Etiology, preeclampsia, eclampsia, accelerated hypertension, and pheochromocytoma. Pathology, Elschnig spots. Choriocapillaries non-perfusion leads to hyperpigmented patches with hypopigmented margin. Seagrass streaks, linear configuration of hyperpigmentation. Focal pigment epithelial detachment. Exudative retinal detachment. Fluorescein angiography shows early hypoperfusion and late leakage. Hypertensive optic neuropathy, malignant hypertension, blurred disc margins, flame-shaped hemorrhages, venous congestion, florid disc edema, and macular exudate. Differential diagnosis, diabetic papillopathy, radiation retinopathy, non-ischemic central retinal vein occlusion, anterior ischemic optic neuropathy, and acute macular neuroretinopathy. Arteriosclerotic retinopathy, Grade 1, increase in arteriolar light reflex due to partial loss of transparency from thickening of the media and adventitia. Grade 2, Grade 1 in addition to arteriovenular crossing changes. Nicking, arteriole hides the view of underlying vein. Grade 3, Grade 2 in addition to copper wire arteriole. Copper appearance of arteriole due to light reflection from a thick opaque wall. Grade 4, Grade 3 in addition to silver wire arterioles. Silver appearance of arteriole due to light reflection from a totally opaque thick wall. Retinal arteriolar macroaneurysms. Acquired saccular dilatation of the wall of retinal arterioles posterior to equator. Etiology: elderly females and vascular diseases, hypertension, arteriosclerosis, and sick vessel wall, as in diabetic retinopathy, vein occlusion, retinal arthritis, cytomegalovirus retinitis, and sickle cell retinopathy. Pathology: retinal arteriole shows one or more spherical or fusiform distension, surrounding fibroglial proliferation, dilated capillaries, hemosiderin deposition, retinal edema, and serous retinal detachment. Circinate exudation, hemorrhages, intraretinal, subretinal, subhyaloid, or intravitreal. Sclerosis and spontaneous closure follow the hemorrhagic episode. Sickle cell retinopathy, proliferative retinopathy resulting from chronic hypoxia. Etiology: point mutation in hemoglobin gene. Mutant hemoglobin C/S replace normal hemoglobin A. Forms SA, sickle cell trait, 8% of African Americans. SS, sickle cell disease, 0.4% of African Americans. SC, sickle cell C disease, 0.2% of African Americans. S-thal, sickle cell thalassemia. Retinal complications are most severe in hemoglobin. Pathogenesis: sickling of red blood cells occurs in anoxic or acidic environment. Polymerization of abnormal hemoglobin results in sickle configuration of RBCs and subsequent vessels occlusion. Sickling results in occlusion of small vessels. Arteriolar occlusion, non-perfusion, neovascularization, proliferative retinopathy, peripheral shunts, and pre-retinal hemorrhages. Pathology: classification: proliferative sickle retinopathy, Goldberg classification. Stage 1, peripheral arteriolar occlusion, ghost vessels, silver wiring. Stage 2, arteriovenular anastomosis, compensatory phenomena. Stage 3, neovascularization. Neovascular fronts, C-fans, arise from arteriovenular anastomosis on venular side. May undergo spontaneous infarction. Stage 4, non-proliferative complications, salmon patch hemorrhages, localized, slightly elevated, red-orange hemorrhages distal to arterial occlusion. Mid-peripheral subinternal limiting membrane hemorrhages. Turn into yellow-white plaque in weeks. Refractive iridescent spots. Hemosiderin-laden macrophages are seen after resorption of red blood cells beneath internal limiting membrane. Black sunburst sign. Localized area of retinal pigment epithelial hypertrophy, hyperplasia, and intraretinal migration. Black sunbursts are located in peripheral fundus. Black sunburst sign. Other ocular findings. Comma sign. Segmentation of conjunctival capillaries. Comma-shaped capillaries appear to be separated from other vessels, seen commonly in inferior fornix. Optic nerve. Intravascular occlusions on optic nerve head manifesting as dark red spots. Angioid streaks, 6%, SS and AS disease. Macular arteriolar occlusion, 30% of patients. Diabetes mellitus, a group of metabolic disease characterized by chronic hyperglycemia with disturbance of carbohydrate, fat, and protein metabolism, resulting from defects in insulin secretion, action, or both. Etiology: type 1 diabetes mellitus, immune-related diabetes, rapid destruction of insulin-secreting cells of pancreas by autoantibodies. Type 2 diabetes mellitus 90%, sustained hyperglycemia which may be undetected for years. Target cell resistance is a main feature. 15 to 20% of patients develop retinopathy. 5 to 12% of patients develop sustained microalbuminuria. Secondary diabetes mellitus, pancreatectomy, chronic pancreatitis, hemochromatosis, Cushing syndrome, and acromegaly. Worldwide incidence: 8 to 12% incidence. 5 to 10% are affected with type 1 diabetes, 90 to 95% affected with type 2 diabetes. Significant increase in the incidence of diabetes during the last decade. Increase across all regions, demographic groups, ages, genders, racial and ethnic groups, and subpopulations. Diabetic retinopathy. Incidence of diabetic retinopathy is related to duration of diabetes. Type 1 diabetes mellitus. Less than 5 years, 13%. 20 years, 90%. Legally blind, 3.6%. Type 2 diabetes mellitus. Less than 5 years, 24% with no insulin and 40% with insulin. 20 years, 60%. Legally blind, 1.6%. Pathogenesis. Chronic hyperglycemia is associated with vascular pericyte loss. Normally, pericytes are present in retinal capillary wall with pericyte to endothelial cell ratio 1:1. Long-standing diabetes is associated with selective pericytes loss. Hyperglycemia and hypoglycemia trigger pericyte cell loss by apoptosis. Pericytes loss result in weakness of microcirculation wall. Microaneurysms formation. Formation of retinal capillary microaneurysms with saccular outpouching of capillaries, venules, and arterioles. Retinal capillary endothelial proliferation into the wall of microaneurysms with basement membrane deposition. Thickened basement membrane. Leakage of blood, plasma, and lipids, hard exudates to extracellular fluid. Arteriovenular connections, shunt vessels. Hypoxia results in collateral AV connections, low blood flow rate. Intraretinal microvascular anomalies do not extend beyond internal limiting membrane. Proliferative diabetic retinopathy. Retinal hypoxia resulting from chronic hyperglycemia, retinal arteriolar and capillary closure, retinal capillary basement membrane thickening, altered blood viscosity, and hormonal imbalance. Hypoxia leads to increase in vascular endothelial growth factor levels and other vascular new vessels promoters. Venular endothelial cells proliferation is promoted by loss of pericytes. New vessels formation results with endothelial channels and some pericytes proliferation. New vessels start intraretinal, break through internal limiting membrane to creep on posterior hyaloid membrane. New vessels growth is accompanied by fibrous and glial tissue growth. Fibroglial tissue contraction results in tractional retinal detachment. Classification of diabetic retinopathy. Clinically significant macular edema. Retinal thickening at or within 500 microns of center foveal avascular zone. Retinal thickening and hard exudates at or within 500 microns of center of F.R.S. Retinal thickening 1 disc diameter or more within 1 disc diameter of the center of F.R.S. Etiology. Incidence 6% after 4 years of diagnosis in type 2 diabetes mellitus. Predisposing factors: younger age, more severe diabetic retinopathy, uncontrolled diabetes mellitus, long duration of diabetes, absent posterior vitreous detachment. Pathogenesis. Retinal vascular endothelial damage and pericytes loss results in fluid leak into Muller cells inducing intracellular swelling, which is reversible. Pathogenesis. Retinal vascular endothelial damage and severe swelling results in death of Muller cells, with fluid and cell fragments deposit in retinal outer plexiform layer. Secondary pressure atrophy on neural retina with progression results in macular cyst, macular pseudohole, true macular hole formation. Severe swelling results in no diabetic retinopathy, no clinical signs of diabetic retinopathy, early changes in retinal blood flow. Non-ocular diabetic changes and complications may be present. Non-proliferative diabetic retinopathy. Microvascular changes limited to the retina and do not extend beyond internal limiting membrane. Mild non-proliferative diabetic retinopathy. At least one microaneurysm. Criteria not met for more severe levels of diabetic retinopathy. Hemorrhages or microaneurysms more than standard photo 2A in 1 to 3 retinal quadrants, and or soft exudate, venous beading, or intraretinal microvascular anomalies. Criteria not met for more severe levels of diabetic retinopathy. Severe non-proliferative diabetic retinopathy. The 4-2-1 rule. Diffuse intraretinal hemorrhages or microaneurysms in all 4 retinal quadrants, or venous beading in 2 or more retinal quadrants, or intraretinal microvascular anomalies in at least 1 retinal quadrant. Severe non-proliferative diabetic very severe non-proliferative diabetic retinopathy. Any 2 or more criteria of severe non-proliferative diabetic retinopathy. Criteria not met for more severe diabetic retinopathy. Proliferative diabetic retinopathy, characterized by extraretinal fibrovascular proliferation extending beyond internal limiting membrane. High-risk proliferative diabetic retinopathy. New vessels at the disc, NVD, quarter to third disc area, MVD less than quarter to third disc area with fresh pre-retinal or vitreous hemorrhage. New vessels elsewhere, NVEs, with fresh pre-retinal or vitreous hemorrhage. Causes of vision loss from diabetes. Diffuse diabetic macular edema, foveal ischemia. Causes of vision loss from diabetes. Ischemic-induced proliferative complications, vitreous hemorrhage, and tractional retinal detachment.